The next lecture by my friend and colleague Jaime Gállego from Pamplona in Spain. He has a lot of experience in oncolic viruses, and he will share with us his experience today. Thank you, Jaime.
Thank you very much. Thanks, Ahmed, for inviting to participate in this meeting. As Ahmed has said, I come from Pamplona. Pamplona is a very small city in the north of Spain, close to France. And you might know it because that's where the San Fermines occur in July, where people run in front of the bulls. That's a silly thing to do because bulls are huge, 600, 700 kilos, rude, and are lethal. And I'm not going to talk about bulls. I'm going to talk about viruses, which on the contrary are microscopic, are very precise, but can also be lethal. And that's what we want them to do. We want them to kill cancer cells. So this is the structure of the talk. And as a brief introduction, I will focus the talk in high-grade gliomas because they are a heterogeneous type of neoplasm with varying degrees of aggressiveness and prognosis, which are majorly dependent on biological and molecular factors. And I'm going to focus the use of oncolytic viruses in this type of high-grade gliomas, mainly glioblastoma, because they account for the vast majority of brain cancers, brain primary malignant tumors, both in adults and children. With this simple slide, I just want to focus the outcome in the past decades, mainly in glioblastoma. There have been very limited changes in the treatment of glioblastoma over the past decades, with the main pillars of treatment still being surgery, radiation therapy, and chemotherapy. The outcome has, however, improved from the beginning, but we are still far away from where we want to be because prognosis of patients with these diseases are still dismal, with earlier recurrence and short survival. And immunotherapy has revolutionized the treatment of many solid tumors and hematological tumors, but this is not the case in brain tumors. And as it has been previously mentioned, there might be some factors avoiding or precluding the effectiveness of these immunotherapeutic approaches, such as inter- and intertumoral heterogeneity with low mutational burden, at least at the beginning, absence of consistent specific tumor antigens, predominance of an immunosuppressant tumor microenvironment, and the variability in and evolution of driving molecular features. And also, as Ahmed said before, the limited accessibility to tumor location, in part, for example, due to blood-brain barrier. So in this scenario, why not oncolytic viruses can play a role as a potential immunotherapeutic for these tumors. The first observations of tumor regressions during naturally acquired viral infections are not recent. The first reports were made more than a century ago, mostly in hematological malignancies, and this prompted the experimental exploitation of native viruses for the treatment of cancer. But it has been in the past decades when the need to target more specifically the cancer cells while sparing the normal ones has led to the development of genetically engineered viruses for that purpose. There are many types of viruses, single-strand, double-strand, DNA or RNA viruses. All of them have or are capable of killing tumor cells or can have an oncolytic activity, but they might differ in some mechanistic properties. DNA viruses have larger and more stable genome, which really facilitates the genetic engineering and an addition of transgenes, while RNA viruses are smaller and have more uniform regulation and relatively higher immunogenicity, which is also important. Among all the viruses seen in the slide, the ones that have most widely been investigated are herpes virus and adenovirus. And how can virus kill tumor cells? Is that real? Well, in theory, the mechanism is double. There's a double mechanism of action. First of all is the proper oncolytic effect. Viruses are going to infect the cell, they are going to replicate in the cell, and they are going to induce the cell lysis, thus killing the cell. This is the oncolytic effect. but by releasing the cell, they are going to release tumor antigens which might induce or elicit a specific immune response, anti-tumor immune response. We also have to add to this anti-tumor immune response the antiviral immune response. So the virus is going to act as a boost for the immune system within the tumor, ideally. Now I will focus on some clinical trials that have been developed first in the adult population, and later on I will go on with the pediatric population. This was, in my opinion, one of the most important clinical trials, mainly because it's the one with the largest sample size, with 61 patients with recurrent GBM, and who received treatment with a poliovirus which was attenuated and had no neurovirulent potential. It was a dose escalation trial. There was one dose-limiting toxicity which was mainly related to the procedure rather than to the direct effect of the virus itself or the drug itself. And importantly, authors reported a plateau of 21% overall survival rate at 24 and 36 months. Although in the figure we see a control arm, this was a non-randomized trial, and the comparison is with historical controls. Then one of the most investigated agents is herpes virus type 1. Today we have 3 generations of these viruses which have been addressed to replicate selectively in tumor cells, to preclude their growth in normal cells. And the last generation, the last herpes simplex virus, which is the G47 delta, its last modification is addressed to enhance the immune response by upregulating major histocompatibility complex 1 expression. And importantly, the 2 trials that were conducted in Japan with this virus were somewhat different from the previous ones, in the sense that in the first trial, pilot trial, the virus was administered twice in 2 separate injections. And in the last trial, 19 patients received up to 6 different injections of the virus at different time points. This later trial showed an impressive 12-month overall survival rate of 84%. And authors described an increasing number of intratumoral lymphocytes with every repeated intratumoral viral injection, while the number of FOXP3 positive cells remained low across the viral administrations. And these results led to the conditional approval of this type of therapy for recurrent glioblastoma in Japan. Now I will focus on another virus, which is the one that we have worked the most, which is the DNX2401 drug. This is an adenovirus serotype 5, which has 2 genetic modifications. One of them is a 24 base pair deletion in the E1A gene, which restricts its replication to cells with the retinoblastoma pathway altered, so sparing replication within normal cells. And the other modification is that it is engineered with an RGD binding motif in the loop of the virus, which increases the infectivity through integrins, which are highly expressed in the surface of tumor cells. So the first trial that was conducted with this virus, that was developed by Juan Fuello and Candelaria Gomez Manzano in Houston, was conducted by the group from Fred Lang, and it was a phase 1 trial, dose escalating trial. They found some nice responses. 5 out of 25 patients had very nice responses. They defined complete responses more than 95%. That's not completely correct, but anyway, there were seen very nice responses just following the administration of this virus in recurrent glioblastoma, and they demonstrated virus in samples in tumor samples, and also an immune reaction with increased number of intertumoral lymphocytes. Then the leader of our laboratory, Marta Alonso, with whom I have the opportunity to work very closely in this project, analyzed if this virus could have any effect in combination with temozolomide, because temozolomide is the main agent used in this type of tumors. So in preclinical studies, she showed that DNX2401 could override the temozolomide-mediated GM arrest in the cycle cell. It could down-modulate the RNA levels of MGMT and could preclude the recruitment of PER300 in the MGMT promoters, thus silencing the MGMT gene. And these are some survival curves in experimental in survival experiments in murine models. So on the basis of this data, we conducted a first phase 1 trial combining the intratumoral administration, a single intratumoral administration of this adenovirus, followed by 2 cycles of dose-dense temozolomide. Survival was not the primary point. This trial was feasible. Safety was acceptable, but there were some serious adverse events that were mostly related to the dose-dense chemotherapy, as previously reported, and data on survival are similar to those other trials with patients with other agents investigated in the recurrent setting. However, I want to show you some images that are quite interesting. These are 2 cases. This is the first one of a patient exhibiting a pseudo-progression initially with a later improvement in the contrast enhancing. This could be a pseudo-response or a slow response to temozolomide. We will never know this because it's a combination and we don't know what has conducted the real effect in this case. And then another case is this one, in which we also see an initial pseudo-progression as shown. This is 1 day after a virus injection. This is 6 weeks later, and this is 4.5 years later. This was an unmethylated patient. But I want to show you something which is curious we have seen in our experience. In those places where the virus is injected or where the catheter passes through, we usually see a contrast enhancement that still continues and does never disappear. So this is something to take into account when we analyze response to this type of therapies. Apart from pseudoprogression, what the Japanese have called immunoprogression, because they have seen that in some cases of this pseudoprogression are related to a very high amount of T cells infiltrate. And very recently, a multi-center trial was conducted with this virus in the recurrent setting on GBM patients, combining with pembrolizumab, with the anti-PD-1 drug in the United States and Canada. The safety endpoint was met. The response rate endpoint, which was 10%, was not met. But it is interesting to show that this type of trials can be performed in a multi-center setting. I have kids. My oldest kid is 13 years old, and there are a series of movies that are named How to Train Your Dragon. This is the best thing about viruses, that you can train them. You can modify them to try to do what you want them to do. And this is something that opens the window to the potential of this therapy. So a new step was to modify the DNX2401 virus. And the next modification that was performed was to include the OX40 ligand insertion in order to provide the co-stimulatory signal to T cells within the tumor microenvironment. And with this virus, we conducted a dose escalation trial with 16 patients. We had no dose-limiting toxicity. It was just a single administration. The treatment was generally well accepted, safety. And we saw some long responders on some responses. These are some 2 examples. This is a young patient with a second recurrence of glioblastoma. He had a recurrence in the anterior and inferior part of the surgical cavity, and we injected this lesion. And 16 months later, we saw this very nice response. I have not shown it here, but through the catheter pathway, there is still contrast enhancement at this point. Okay, so this is something important in the follow-up. And this was an 81-year-old male patient with a first recurrence of glioblastoma. This was the recurrence, and that's where the virus was infused, and he showed a nice response. All these patients relapsed later on. Now I'm going to focus, because of the safety data in the adult population and these hints of efficacy to the pediatric population. And this is a very important trial that was conducted in children and young adolescents aged 7 to 18 years with recurrent supratentorial IDH wild-type gliomas. I have put this image, just to show how there is a nice reduction in the tumor in the contrast-enhancing area. But as you see, there are some cystic lesions that appear in the place where the virus is injected. This is something that we have seen also in our trials, in the trial that we'll present later on. So these are also some changes that we have to take into account when follow-up. And they also show that there was a brisk infiltration of CD8 cells, suggesting an immune response and a shift from cold to what is called hot tumor. So we focused our research in the laboratory in the formerly named DIPG, in diffuse midline glioma in the pons. And it took us about 5 years to develop a reproductive model, murine model of DIPG, which is shown here. Once we had this model, we were able to demonstrate that DNX2401 has a direct oncolytic activity in these murine models of DIPG, and it can elicit an anti-tumor immune response. Because treatment of DIPG is based on radiation therapy, we also analyzed the effect of the virus with radiotherapy, and we found in survival experiments in murine models that there could be a synergistic effect of both therapies. So this prompted us to launch a phase 1 trial in 12 patients aged 3 to 18 years old of a single dose of this virus within the tumor in the pons, followed by standard radiotherapy. This was a phase 1 trial. Feasibility was demonstrated. Most adverse events were mild to moderate and were generally fever, nausea, vomiting, and fatigue. There was one neurological worsening, grade 3, that was related not really to the virus but to the proceeding. We knew that we were going to pass the pyramidal tract with the dactylography that was done previous to the surgery, but the patient recovered to a phase 2 hemiparesia later on. And these are 3 cases who exhibited a partial response. Again, this was virus treatment followed by radiation therapy. So we cannot say that this is the virus, okay? But we found these responses, and as I told you before, we saw some cystic lesions in the area where the virus were infused. This is anecdotal because we cannot obtain firm conclusions from so small sample clinical trials. But yes, the median duration survival was 18 months almost, and well, this was something encouraging. We had the opportunity to analyze the tumor sample of one patient. We did a biopsy prior to viral infection injection in every patient. At baseline, all patients had very scarce T-cell infiltration, and the main immune cell infiltration was myeloid suppressant cells. We had the opportunity to check the tumor in one case at the moment of relapse after the treatment. We saw that there was an increased intratumoral lymphocyte count with a dramatic drop in the myeloid compartment, and at autopsy, the landscape turned back to the baseline, to how it looked like at the baseline. So on the basis of this study, we are now trying to open in the next 12 months a phase 2 trial, multi-center, with some centers in the United States and in the Netherlands with the Princess Maxima Center. And also we want to analyze or examine the potential role of this virus in other pediatric high-grade tumors. Finally, I will conclude with some points regarding safety. Oncolytic virotherapy has shown to be well tolerated in general. Because of its selective replication in tumor cells, we do not expect to have off-tumor effects, and most adverse events are manageable. Fever is very commonly seen the 24, 48 hours following the treatment, and this might be related to viral replication and associated immune activation, and it disappears spontaneously. The future landscape of immunovirotherapy is plenty of opportunities, but also of challenges, of difficulties. The nice things, as I said before, how to train your dragon. I mean, we can enhance tumor selectivity. We have to modulate the antiviral immunity and to strengthen the anti-tumor immunity. And this is one of the main problems. We don't know what type of lymphocytes are we stimulating. But of course, we can develop a new rearmed virus to overcome the immunosuppressive tumor microenvironment. We have developed in our viral platform a new viruses which has incorporated the 4-1BB ligand expression in tumor cells. So we are planning to conduct a phase trial with this virus. And of course, there is always the possibility of conventional strategies. We will not move forward without other treatments. But the challenges are, ideally, we should be able to administer this in an intravenous way. This would be ideal, but it's rapidly cleared, the virus. There are many strategies to avoid this early clearance. When is the optimal treatment timing? This is something that's not really known. Whether single or multiple administrations have the same effect is an unanswered question. Smaller or larger tumor volumes, in our opinion, what we have seen is that when targeting smaller lesions, we have better responses. And that's not very logical when you think about the mechanism of action of the virus, but that's what we have seen in these early phase trials. And of course, we need reliable response assessment criteria because of all the changes that I have shown you. Finally, to conclude, I have just talked about early phase 1 clinical trials. We cannot obtain firm conclusions from them. We can just say that this treatment is feasible and it can be safe, but there are hints of efficacy and they have allowed us to check for tumor microenvironment changes. So I think there is a long way to go, but this is a window to hope, I hope.
Thank you very much, Jaime, for this interesting presentation. Any question for Jaime? Jaime, a question about the efficacy and the toxicity of the DNX2401. You said that it was modified to target cells with disrupted ARB pathway. Did you check for ARB pathway? We know that 80% of glioblastoma have a disrupted ARB pathway. Do you check before injecting the virus or not? Or did you see any correlation?
Not really. We assumed that it was altered, but we did not check it.
You don't check it, so no correlation with.
But it's an inclusion criteria always, those tumors that live from many syndromes and so on. But we did not check it in these trials.
The samples. Okay. Other question for Jaime? Yeah.
Very short one. Do you have information about neuroinflammation in CSF in these patients?
It's a great question. We have never planned to obtain CSF from these patients. We know that the virus can shed because we can detect it in the blood, so we will be able to detect it in the CSF. In the planned trials, we might collect CSF if an Ommaya catheter is placed in the children population. I'm not so confident with placing Ommaya catheter for this treatment. We are doing this because of the example of CAR-T therapies trials with children.
Okay, thank you very much, Jaime.